Артур, можешь это блоки перевода дать профессорам? Может, надо?
Can I touch? Yeah. This.
Владимир, можно вас на секунду?
It's okay. This. Okay.
Ну что ж, доброе утро. Сегодня третий день нашей конференции. Сегодня план, в принципе, похож на первые 2 дня, но в отличие от других дней, сегодня у нас под конец будет живая хирургия. Вот, первая лекция по анатомии борозд и извилин головного мозга, базальный аспект. Выступать будет профессор Максимилиано Нунес.
Спасибо. Can we delight a little bit more? Good morning. This morning, I think this talk is very short because we see every part of the brain in the laboratory. But today I will talk about just the inferior phase of the brain. And if the auditory wants, if the professor wants, we can talk after this talk about the pons and the foreventricle, the approaches. I hope you like the talk. Okay. The inferior surface of the brain, we need most to know some specific part, some specific areas, but we know, sorry, 1 minute. Yesterday we talked about the lateral surface of the brain. Also we talked about the middle phase of the brain. But today we try to explain the inferior phase of the brain. It's not so long to understand, but the inferior phase of the brain. This is the totally full view of the inferior phase. We have some structures to understand. The most important, of course, for the inferior phase is the uncus and the hippocampus formation, of course, part of the temporal lobe, of course, like yesterday we talked. But in the inferior part of the brain, in the anterior portion, you have some sulcus and gyrus can be identified in this area by 1, 2, and sometimes some transversal sulcus. The shape is like an end, and Russian is like an end. But this inferior view is more nice to see without vessels, and you can see the different parts. Temporal lobe, of course. Here, the occipital lobe for the inferior face. If you put one line at this level, you can divide one portion, the posterior portion of the inferior face of the occipital lobe and the occipital pole. Here, in the midline, in the center, the brainstem, of course, with the posterior part of the corpus callosum. The anterior part, you have the optic tract. Here, I made the cut in the anterior portion of the chiasma, and in the anterior portion of the frontal lobe, by the inferior surface, the most important structure here are this sulcus and gyrus, this area. This area, you can see this sulcus, here again, a little bit more down, and one sulcus here. This sulcus make the shape like an end with one gyrus lateral, one anterior portion, one medial portion, and posterior if you take off this area of the temporal pole. Medial to the olfactory nerve, medially to the olfactory nerve, you have sulcus and gyrus of the inferior face of the frontal lobe. Here, the olfactory nerve. In this area, just close to the midline, here, the parolfactor gyrus. Sometimes in the vascular surgery, you must be removed some part of the olfactory gyrus to reach the aneurysm, the anterior communicator artery sometimes. If you see in the posterior part, the trigono olfactory, and the anterior perforated substance, chiasma, of course, mammillar body, and the brainstem. We made a cut at the level of the superior colliculus, like you know in this picture. Around of the brainstem, you can find the cistern of the base, the crural cistern, interpeduncular cistern, crural lateral and little bit anterior, and the ambient cistern. Yesterday, we described this totally cistern around of the brainstem. In the anterior portion, you have here the carotid cistern, here chiasmatic cistern, and if you turn this chiasma to below, you can find the lamina terminalis cistern. Again, but we put some colors to be more didactic, to understand the disposition, the different part of the inferior face of the brain. Yesterday we talked about this when described the temporal gyrus, the fusiform gyrus, parieto-occipito sulcus, inferior temporal gyrus, temporal pole, occipital area, and occipital pole. If you see again a closer view, you can understand for the inferior face, the most important is the hippocampal formation, the uncus and hippocampal formation. Again, the renal sulcus, here parahippocampal gyrus, fusiform gyrus, here inferior temporal gyrus, the anterior part of the uncus, the apex of the uncus, you see the relationship with the crural cistern and the relationship for the posterior area with the ambient cistern. Here, pulvinar of the thalamus is hidden behind. Now you can see the apex and the posterior part, the uncal notch, and of course, in the upper part, optic nerve, optic tract, anterior perforated substance with many vessels here running to the basal ganglion. Here, crural cistern in white in the first time. In the second time, the ambient cistern around of the brainstem, of course. And here below, you see the medial surface of the temporal lobe the uncus, and the relationship always with this nerve. This nerve is the third nerve. You can see in green, it's very close. A closer view of the inferior part of the frontal lobe. This is the inferior part. You can see. This is the shape of the end letter, like an end letter. One ramus here, one sulcus in the upper part, and the inferior part, the middle, and one superior and medial sulcus, and inferior and medial sulcus. We can divide in 4 gyrus: anterior gyrus, posterior, medial, and lateral gyrus. The medial gyrus is just very close with the olfactory sulcus and the olfactory nerve for the inferior face. This is the total view of the posterior now, the posterior part. You see the temporal lobe, and the posterior part, occipital lobe. It's so very easy to understand this part. But here we dissect from below the inferior surface of the brain to understand the disposition. This view, in this picture, you can see from below the inferior face. Can you see the posterior part of the corpus callosum? Of course, the fornix, the mammillary body, anterior commissure, optic tract. We cut this part to understand the position of the anterior frontal part of the ventricle, you see. And in the right side, we dissect this tract, uncinate fasciculum, here in the lateral portion. If you take like a landmark, the olfactory nerve, behind olfactory tract, behind anterior perforating substance, here, hidden inside in the deep here, anterior commissure, of course, and posterior part, apex and anterior part of the uncus of the temporal lobe. In the anterior portion, these fibers coming from the medial face of the brain. You remember yesterday what type of fibers are. This is fibers from the cingulum, from the medial surface, coming from the medial surface, and they run from the inferior face to reach the anterior portion of the temporal lobe. If you remove the floor of the temporal part, in this case from the atrium and the temporal horn, you can find the choroidal plexus running around on the choroidal fissure. Here we remove the floor, and lateral to this structure you can find in the first time here these fibers more medially the optic radiations, and more laterally, very well to understand, the ELF. The ELF is lateral to the optic radiation, a little bit more superficiality, of course. And here, the inferior temporal gyrus. This is a closer view. Why? Because here, yesterday we described the hippocampus and the uncus and many sulcus and gyrus inside, in the head of the hippocampus, of course. But in the lateral view, a closer view of these fibers. I talked with you about these fibers are fibers of the cingulum, of course. Here, choroidal plexus, optic radiation, and ELF, lateral always to this tract. A closer view with another situation, you can see the dentate gyrus, the fimbria of fornix, and the head of the hippocampus here, anterior portion, apex, posterior portion, entorhinal area, anterior perforated substance, optic tract, and the defense structure like we all know. Here, the temporal part without floor. If you describe this area with any numbers, sorry, in the first time, again, dentate gyrus, here, of course, lateral and more deep, the fimbrodentate sulcus, here, between both, here, the fimbrial fornix, lateral genicular body, choroidal fissure, here, the choroidal fissure is here, between the thalamus and the fimbrodentate, here, inferior choroidal notch, inferior choroidal point, here, the place where anterior part of the amygdala, entorhinal area, fusiforme gyrus, collateral sulcus, and posterior part, uncinate gyrus, here, the intralimbic gyrus, and the middle, the banda of Giacomini is the name, of course. Here, apex of the uncus. Yesterday we talked about this. Here, the ambient gyrus, and in the big view, every part totally dissected. You can see the dentate gyrus, the fimbria, here posterior portion, apex, anterior portion, entorhinal area. You can see the relationship of the apex of the uncus, the hippocampus, with the cerebral peduncle here at the level of this area. This area we call crural system. The posterior part, the ambient system. And in the last picture, I think we remove the roof of the temporal horn to one side and the opposite side, but it's more interesting this area with the amygdala, when the head of the hippocampus, body, crura, fornix, etc. Here we see the attachment of the choroidal plexus, here fornix, and here dentate gyrus, and the relationship, of course, of the head of the hippocampus with this cister, the crural cister. In the anterior face, interpeduncular cister. Posterior at level of this area, ambient cister. More posterior, here at the level of the pineal gland, here the quadrigeminal cister. I want to show you some case of the basal surface of the brain. We do this surgery in my hospital. It's very short, but we use the neuronavigation to understand the position, the incision. It was in the surface, in the inferior surface of the temporal lobe, in the posterior part, very close to the Lave vein. We use some soft retraction to understand and expose the inferior part of the temporal lobe. Some dissection and coagulation. The lesion was there. You can see the different aspects of this portion of the brain. We use neuronavigation, of course, but we try to respect of the veins, clear dissect, and remove this area. Was very soft to remove. The color is a little bit different. We split the sulcus to understand the position of the tumor, the posterior part of the tumor. This is very short, but it's just to understand this position, in this case, to understand where is the position of the tumor. This is the CT scan control, and the resection, in our opinion, was very, very fine, and the patient is very, very well today. Was 4 weeks ago. The lateral view with totally resected lesion. Okay. This is in memory to the Professor Roton. I think was an amazing person. I think it's very important the concept he transferred to the neurosurgeon, to the young neurosurgeon in the life. Thank you, спасибо. Thank you very much.
Thank you, профессор. У кого-нибудь есть вопросы в зале? Если вопросов нет, то у нас по плану сейчас кофе-брейк.
Yeah, if you want, I can to show this part to finish some letters are in Spanish because but I want to say sorry for that. But it's just to see some part, the pons and the medulla oblongata and the posterior part. In fact, the surface of the foreventricle. I was talking about brainstem anatomy yesterday, but just for midbrain. Today, I want to show you the approaches to the pons, to the medulla oblongata in the lower part here, and from the back to the foreventricle. To start this talking, the access to the ventral protuberantia area you can divide in 4 places. Here, one access is medial to the corticospinal fiber tract. Yesterday, I dissected for you the corticospinal fiber tract. You can remember this. This area, I told you, this is the area of the corticobulbar, corticonuclear fibers coming from up to down. You can touch this area, but if you want, of course, you can enter here a little bit medial to the corticospinal fiber and inferior to the origin of the third nerve. In second place, you have in the D point, medial to the 5th nerve, this area. This area we call supratrigeminal area. Inferior to the B point and lateral to the 6th nerve, medial to the lower part of the 5th nerve, you can reach this anterior portion of the pons. The C point is the peritrigeminal area. Here, 1, 2, 3. And in the end, the D point, lateral to the 5th nerve, inside in the middle cerebral peduncle. You can touch this area without damage of the corticospinal fiber tract. You can observe these points are around of the corticospinal fiber tract. The point is how can reach this area, the anterior surface, the very, very ventral is a challenger for us. That's the reason because I put this picture. This picture is just to understand today how useful is the endoscope approach when you can reach the anterior and ventral portion of the pons. This is a very useful tool. If you see, you can reach the anterior portion of the pons, but the problem is what structures you have here, what is the disposition of the basilar artery, how is the shape, how long, is for lateral, is in the medial or is like a dolic basilar artery. This is a very exciting challenger for us. This is the view for endoscope in one specimen. I dissect this specimen, and this view can show the disposition in the middle line of the basilar artery. Of course, the anterior face of the pons is here. You can see the basilar artery, but what is the place of the corticospinal fiber tract? If you are the surgeon in this case, where is? Is here, is behind of the artery, is more laterally, where is? Okay, the corticospinal fiber tract coming here, in the middle between the artery here and the 5 nerve here. This is the 5 nerve. This is the 5 nerve in the opposite side. This nerve is the 6th nerve running to the Dorelo canal. Here, the basilar artery. The problem here is for endoscope, if you reach this area, you can damage the corticospinal fiber tract. But for me, I think we must be learned too much about how useful is the endoscope in this case. This is the real view for endoscope approach to the anterior face of the pons. This is the basilar artery. If this is the basilar artery, this is the top of basilar. If this is the top, this is the posterior cerebral artery. Of course, this artery is the pecum, and below, the 3rd nerve, below, superior cerebral artery. This division is at the level, the junction between the mesencephalic area and the pons area. In this area is the division. You can see in the right side here, posterior cerebral artery, here, superior cerebral artery, and between both, the 3rd nerve. Reach this area is real challenger for us. Here, for endoscope, you can reach also the lower part of the basilar artery. The lower part of the basilar artery is by the junction between the vertebral artery from the left side and from the right side. In this way, with the endoscope approach, you can reach the upper part and the lower part in the different approaches, of course. This is the anterior surface of the pons. Yesterday in the lab, one colleague showed me some pictures about brainstem. Perfect picture, beautiful picture, and I try to put today this picture to understand how is the pons for us. I read in many books. When I was a student, I read how is the pons. Yeah, the anterior face, middle cerebral peduncle, 5 nerve, motor roof, here sensorial roof, 7 and 8 nerve, 6 nerve, the junction between the pons and the medulla oblongata. This sulcus divides 2 portions of the brainstem. Of course, olive, many structures, but the point and the question is what you can find behind of these transversal fibers. Why? Because the corticospinal fiber tract is hidden. And today I will try to show you, like yesterday, if you can dissect this part, this transversal fiber, I showed you yesterday how is the disposition of the corticospinal fiber tract. But nobody knows because these layers, this transversal layer, you have 3 types of transversal layer. Very superficiality transversal layer. One second layer, the name is stratum complexum, and the most posterior layer, stratum terminale, is between the foreventricle and the pons. But I try to remove some transversal fiber to show the real face of the pons. I know the pons in that way, in this way, but the pons really, this is the many examples to understand the position of the different cavernoma. Is no matter. I want to show you very fast, but the real anatomy of the pons for me is this. The pons have many tracts, transversal tract, corticospinal fiber tract, Stratum here, stratum superficiality, here stratum complexum, and most posterior stratum terminali. This is the real face of the pons. If you can understand the disposition of the corticospinal fiber tract, you can't damage in your approach to the patient. For example, one surgical case, this case in my hospital, a young boy here, one cavernoma here, the same cavernoma close to the 5 nerve in the peritrigeminal area. To access to this peritrigeminal area, this schematic example can show you the disposition of the peritrigeminal area. The peritrigeminal area is medial to the bone of the 5 nerve, and you can enter very rect in this direction, no more to 11 millimeters. Why? Because you can damage the motor and sensorial nucleus of the 5 nerve. If you enter in the wrong direction, you can damage these structures: medial lemniscus, spinothalamic tract, and central tegmental tract. Here again, if you go more down between the 5 and the 7 and 8 nerve, if you enter in the right direction, in the correct direction, you can't damage the corticospinal fiber tract. But if you enter very deep, be careful, because you can damage the lateral lemniscus and spinothalamic tract. But if you enter more deep, you can damage here the nucleus of the 7, and of course more deep in the surface of the 4th ventricle, the nucleus of the 6th nerve. This is the vascularization, but it's no matter. We do in this case this approach, the pretemporal approach, transzygomatic approach, and anterior petrosectomy in this case. Why? You can see we divide here, in this case, the zygoma. We take off the zygoma. We expose the bone, sphenoidal bone, temporal line, here the calf of the temporal muscles, here the temporal bone, here the pterion, of course, everybody knows that, and remove here, the craniotomy can show you this area, frontal lobe, temporal lobe, the base of the middle temporal fossa. If you open the dura mater, you can see this picture here, frontal, temporal. Now I open the dura madre, and to show you by the peeling of the middle fossa, the meningeal artery will retract the temporal pole to expose in this way here the trigeminal nerve, here trigeminal ganglion, B3, B2, and in the upper part B1. We remove the anterior portion of the apex of the petrosal bone to expose the dura mater of the posterior fossa. If you open this area, you can reach this triangle. If you see in the deep, what is this? This is the lateral and anterior face of the pons, posterior dura fossa, and this approach you can reach this area. If you remove more, you can understand these windows. You have two windows. In the upper portion of the 5 nerve, this window is very big window. You can access to the pons, to the anterolateral face of the pons by this approach. And of course, in the below of the 5 nerve, you can access to this area. This is below. This is the upper part of the 5 nerve. You can see this area. You can see this area. Of course, this approach can show you the 6th nerve. You can access to the anterolateral face of the pons by this approach. 1, 2, and this is the totally full dissected with the B1, B2, B3, the motor root, of course, the trigeminal ganglion, the 5 nerve, the apparent origin, and this full view can show you the upper window between the 5 and the 4 nerve. If this is the 5, this is the 4. This is the 4. Here you have the 6th nerve. Here the 3rd nerve. Here the lower part can show you the complex of the 7 and 8 running to the internal acoustic meatus. Here and here the lower window. Totally full dissect. You can see it's very nice. The anatomy is very nice. You can access to this area and to this area. If you make a practice in the lab, you can understand in the surgical position this area. The carotid artery with many parts, like we all know. You see? Perfect. The approach is for in this line, and in this line. This area you can reach here. This lower part for this area. It's very didactic. This is the control with totally this resected cavernoma of the patient. And the most important for everyone is this, totally recovering. For me, that is the more important. This is the different view. If you put your eyes in this point, you can see the epitrigeminal area. See, if you access for the subtemporal approach, you have this vision in blue. In blue, you can see everything is the most important vision for the epitrigeminal. You can reach all this area for this access, for example, subtemporal, pretemporal approach, etc. This approach, supratrigeminal area, is very short. It's very, very short. It's not the most useful. And if you see by the retrosigmoid approach, you can see in this way for the green line. Why? Because your eyes is here, the spatula is here, retract, and you can see this area, lateral transpeduncular entry zone. And if you put the spatula a little bit more lower, in the lower part, in this area, you can see the peritrigeminal entry zone, around of the 5 nerve. All these entry zones are around of the 5 nerve. This is the more small, and the most important for me is the epitrigeminal, in the second place, the peritrigeminal area. To don't touch this, the corticospinal fiber tract, running from top to down. This schematic is just, sorry. This is the tractographic reconstruction. We do this with Dr. Fernandez Miranda in Pittsburgh to understand the disposition in the tractographic of the many tracts. This is the peritrigeminal entry zone. See, if this is the peritrigeminal, you can see the area below of the 5 nerve, of course, peritrigeminal area, medial to the 7 nerve, inferior to the 5 nerve, and lateral to the corticospinal tract in blue. You see? Of course. Here in the frontal view, supratrigeminal area below of the 3rd nerve. Here, epitrigeminal entry zone in the upper part of the apparent origin of the 5 nerve, and lateral transpeduncular entry zone here inside in the middle cerebellar peduncle. If you have some disease, some cavernoma here, this is the best approach, lateral transpeduncular entry zone, because the only fibers running here are from the medial cerebellar peduncle. You don't touch the 5 nerve, the 7, or the 8 nerve. You don't touch nothing. And the corticospinal fiber tract in this approach is very far here. It's very, very far. Okay, it's no matter this. If you remove the anterior portion of the pons, the more superficiality transversal fibers, what can you see? You can see these fibers. The more deep layer of the fiber are here, the transversal deep fiber of the pons. Here, the corticospinal tract. Yesterday, we dissect this. You can see how is the continuation. I remember yesterday with the doctor, we dissect with my colleagues these fibers, and I show you the disposition. You can touch, you can dissect in the same way. You can see the disposition. It's very clear. Of course, this disposition is in the specimen, but in the real life, it's more difficult to be identified. If you see this area, I remove the corticospinal tract in the pons in this side. I remove. Of course, if you remove this corticospinal tract, what you find behind? You find first the stratum complexum is the second layer of the pons, and below of this layer you find this, the more deep layer. But the point is, what is this structure? This structure is a very little nucleus. It's inside in the pons. It's between the corticospinal from one side to the corticospinal from the another side. This nucleus is the magnocellular nucleus of the pons. It's connected with another nucleus. What is the another nucleus? It's in the upper part, here. You go, and you touch this, the interpeduncular nucleus. If this is the interpeduncular nucleus in the middle of the interpeduncular fossa, you remember this is the substantia nigra, third nerve to the opposite side, and here, the connection with the avenula. This is the connection between the interpeduncular nucleus with the avenula in the back. Okay, this nucleus makes connection with this, but now, below to this nucleus, what you find? This tract. I make a cut here. Why? To understand the disposition of the fiber, because these fibers running from one side to the opposite side. Yesterday, Professor Subianov tell me, where is the lateral lemniscus in the lateral face of the brainstem? Okay, the lateral lemniscus is hidden. It's hidden below to the fibers, but the lateral lemniscus born from these transversal fibers. How is the name of this structure? Running from one side, crossing the middle line, and reach the lateral surface. This is the trapezoidal body, the origin of the acoustic system. This is the trapezoidal body. It's very interesting to see. You see? Trapezoidal body. The fibers cross one side to the opposite side. This is the transversal fibers. Here, this is the transversal fibers, corticospinal fibers tract. And you see, very interesting point, this is the peritrigeminal area. If you reach with your eyes for one subtemporal approach, you can reach this area, the peritrigeminal area between the corticospinal fiber tract and the five nerve. If you enter in this area, you can reach this portion of the pons without damage of the corticospinal fiber tract. Here, supratrigeminal area. The supratrigeminal area is medial to the corticospinal fiber tract, but is more is not so a specific point, in my opinion. Okay, I want to go on. If you remove the anterior face of the pons, if you remove the more superficiality layers, you can reach the foreventricle from anterior to posterior. I dissect from anterior to posterior to understand this dissection. If you remove the anterior portion of the pons, what you can reach? What you can find? You can find the last layer of the transversal fiber. This layer is the more deep layer connecting one side with the opposite side of the cerebellum. This layer runs from one side to the opposite side. But what happens if you take off this layer? You can find this layer here. These fibers running from below to up. How is the name of this tract? This tract runs behind of this fiber, but run in the opposite orientation. This fiber go from here to here, and these fibers running from inferior, run, and go to the thalamus. What is this tract? Medial lemniscus tract. This is the medial lemniscus tract. It's the most deep tract. Yesterday in the sagittal cut in the laboratory, I showed you the medial lemniscus. The shape is like a C, running from below to up to the anterior nucleus of the thalamus. It's like a C. The shape is like a C. If you understand this anatomy, you can make a good programmation if you have one disease, like a cavernoma here in the middle of the pons. You can think about who is the best approach, subtemporal, anterior, peritrigeminal, supratrigeminal area. What is the point here? Is to discuss what is the best approach, but you must understand this anatomy, because the anatomy change with the disease. The anatomy change with the cavernoma or another disease, of course. This is, of course, everybody, no matter this point, but the supra. Okay. If you remove more deep fibers, now I remove the medial lemniscus in part, and I remove the transversal fiber. You can see, you don't see anymore the transversal fiber. But what happens? If you remove the most transversal fibers here, you can reach, you can reach, it's like a walk, you walk inside in the four ventricles. You see? I make a window in the middle line of the four ventricles. The point is I dissect from the anterior to posterior, not from the back, from anterior to posterior. And now you can see here, yesterday I talked with you about the problem if you damage this tract. Here one tract and here another tract. They are twins. They are twins, like brothers. What is the name of this tract? Perfect. Medial longitudinal fascicle connecting third nerve, fourth nerve, sixth nerve. Of course, if this is the medial longitudinal fasciculus, this is the floor of fourth ventricle. The point is I dissect from anterior to posterior. This is the only difference. If this is the medial longitudinal fasciculus, what is this? What tract? It's very close. The name is tectospinal fiber tract. The tectospinal fiber tract. What is this? Here, transversal fibers? No. This is the medial lemniscus. And the more superficiality layer, here, transversal fiber, the more deep. More deep transversal fiber, medial lemniscus, tectospinal fiber tract, medial longitudinal fasciculus from anterior to posterior. Okay, I remove some part of this last tract. And if you remove the medial lemniscus at tectospinal tract, you can find this. 1 minute, it's just to be more deep. You can find this. Finally, you reach all anterior face of the foreventricle. Again, we can repeat. Medial longitudinal fasciculus exists? Yes, it's real. It's real here. Lateral tectospinal fiber tract connecting the tectum with the olive. Lateral to the tectospinal fiber tract, central tegmental tract. Lateral, the nucleus, the mesencephalic nucleus of the 5 nerves, running from the peritrigeminal area to the mesencephalic portion of the brainstem. And laterally to this nucleus, the mesencephalic nucleus of the 5 nerve, what is this with this color? Nucleus ceruleus. If this is the nucleus ceruleus, you are in the superior cerebral peduncle. The only difference in this picture is your vision change because I dissect from the anterior to posterior. Yesterday I showed you the floor of the foreventricle to posterior and anterior. This is the only difference. If you know the anatomy, you can access very, very well to the different portions of the brainstem. I remove everything. I make a hole, very, very big window in the anterior surface of the pons. Again, here, these transversal fibers are here, oblique, no transversal, oblique is the mesencephalic nucleus of the 5. Here you can see the nucleus ceruleus. What is this? The nodular portion of the cerebellum. What is this? Lateral recess. And here you can enter to the foramen of Luschka. Perfect. What is this? If this is the foramen of Luschka,
This is the colloidal plexus, of course. And this is foramen of Luschka, of course. If you are in the Luschka foramen, the wall, the posterior wall of the foramen de Luschka, what structure I talk about here? Superior cerebellar peduncle is the lateral wall of the upper part of the foreventricle, and also is the back of the foramen of Luschka. We pass very fast we don't have more time, and this is the sagittal cut to understand the disposition of the corticospinal tract. You can observe very well the corticospinal fiber tract is not rect. These fibers don't come in from the top to down, very straight, very rect. No, it's like a twin turn. They turn, make a curve in the three-dimensional disposition. You can see the disposition of these fibers. You can see how is this disposition of the more ventral fibers coming. Are ventral, but in one moment they are posteriorly. You see? This central portion of the pons, you can, mostly of the time, you can see many corticospinal tracts. Yesterday in the laboratory, we do some demonstration. You remember the sagittal specimen where I can remember show you the corticospinal tract and posterior. What is this? Medial lemniscus. It's simple. This is the medial lemniscus. The medial lemniscus can divide the pons in one anterior portion and posterior portion. And if this is the medial lemniscus, this is the floor of the foreventricle. And if this is the floor of the foreventricle, this is the quadrigeminal plate, inferior and superior colliculus. Anteriorly, you have the red nucleus. I make a cut to understand this part we call magnocellular portion. This lower part, the books say the name is the parvocellular portion. It's no matter. But what happened with this red nucleus? You see this tract? Okay. You have medial longitudinal fasciculus. Here, more anterior tectospinal tract, and more anterior and ventrally central tegmental tract. It's true. If you dissect from the front, if you dissect from the back, or for the middle line, you can understand the disposition of many tracts. What is the point? If you have some disease here, like yesterday I talked, some cavernoma, yesterday I talked about the access, inferior to the inferior colliculus, you can enter in this area. But if you go very, very deep, not just damage the aqueduct, also you can damage this part with this tract. Here, the third nerve and the substantia nigra and many structures, you know. To understand this approach, we do pre-sigmoid approach to understand the access to this portion. This is the step-by-step of the drilling of the mastoid. It's no matter here, one, everybody knows this, it's no matter. To access to this tumor, for example, we do this case in my, okay, I try to show you the step-by-step, the pre-sigmoid approach. Everybody knows this approach. You can see this area, you can see in this specimen how is the window. If you remove the bone, you can access to this area, and inferior to the 5 nerve. In this picture, you can see many windows. One window between the 3rd nerve and the 4th nerve. In this window, you can see the lateral surface of the brainstem. Between the 4 and 5 nerve, and below to the 5, between the 6, 7 and 8 nerve. You can reach many, many windows to understand why the pre-sigmoid approach is very, very important to expose the anterolateral surface of the brainstem. This is okay, it's no matter. Again, to be more fast, this area you can reach, total view. Again, with the pre-sigmoid approach, you can enter in this area between the 4 and 5 nerve, here, and between the 5 and 7 and 8, and here, what is this nerve. This is the sixth nerve. 7 and 8, and the lower cranial nerve. The lower cranial nerve, this is choroidal plexus. This is the 7 and 8. 6, basilar artery, anterior surface of the pons. 5 nerve, this is the medial cerebellar peduncle. This is the motor root. Here, the superior cerebellar artery. Here, the 4th nerve, 3rd nerve. Here, the lateral surface and lateral. What is this? Perfect. Lateral mesencephalic sulcus. Of course, this. We do this approach for this case, step by step, very quick. The sigmoid sinus, Traumann's triangle. We open the Traumann's triangle, and of course, you can expose the windows between 7 and 8 in the upper part, in the green line, and in the orange line between the 5 and 7 and 8, and superior to the 5 nerve. This area you can expose this area, and below to the 7 and 8 nerve, of course. This is the area can you reach with this approach, pre-sigmoid approach. The pre-sigmoid approach exposes this area between the 5 and 7 and 8 nerve. From the top and from below, between the 5 and the 7 and 8 nerve. And here, of course, the corticospinal fibrous tract in the didactic demonstration. To access transolivar approach to this area, you can reach the medulla oblongata for this sulcus, preolivar sulcus, transolivar access, or postolivar sulcus. It's okay, it's very quick. You can see the different, this is the axial cut at the level of the medulla oblongata. You can see the pyramid. You can see here the olive, totally dissect, the origin of the 12th nerve running from the back of the pyramid in the postolivar sulcus, and here the 10th nerve, preolivar and postolivar sulcus, sorry. Here, far lateral approach, step by step. I can stop in this slide because everyone know this approach. I open the dura madre, and this picture will show you the cisternal in the back of the lower part of the cerebellum, and we can expose this area, medulla oblongata, the lower cranial nerve, 11. You can see the 11 here. I push the suboccipital face of the cerebellum. In this way, you can expose this cavernoma here. We access to this cavernoma. Previously, we do one tractographic. The cavernoma push the corticospinal to medially, like you can see perfectly in the tractographic. Here, we remove part of the posterior arc of the C1. Here, we expose the vertebral artery, of course, and open this area to access to the lower portion of the medulla, of course. And here, you can open the dura madre and see many structures inside in this area. Many, it's very, very important. Why? Because this cavernoma is in the olive. It's inside of the olive. You can enter here or transolivar or postolivar sulcus. Two options. We enter postolivar sulcus. You can see very, very well. This point show you the olive, the posterior and lateral surface of the medulla oblongata, 11 nerve, of course, here, posterior part of the medulla oblongata. If you push a little bit more up this area, you can see the obex, the lower part of the foreventricular floor. Okay, we dissect many fibers. I can stop because it's so long, but if you see, this is the corticospinal fibrous tract running from top to down. I make a cut here. Why? If you know, the corticospinal fibrous tract is anterior, is superficiality to one tract behind it. What is the name, the tract behind of the corticospinal tract? Where is? It's here. Here. This tract. You see the fibers is the same way to the corticospinal, but it's more deep. This is the medial lemniscus. It's simple. The first tract you can find behind of the corticospinal tract is the medial lemniscus here. And I make a window, a little window here. Why? Because the books say the olive is connected with the olive for the opposite side by layers transversal fibers. These fibers here we call olivar fibers. These tracts connect one olive with the opposite olive. When this connection is made between both olives, these fibers enter in the olive, make a round, and after that go for the inferior cerebellar peduncle to the vermis of the cerebellum. That is the point. It's very interesting. Here, you see, totally dissected. This is the corticospinal tract. I make a cut. I respect the corticospinal. This is the decussation in the lower part. But the most important to understand, of course, is this structure, the olive. You must respect the olive. But in some parts, in some cases, if you have one cavernoma, you can enter transolivar access. The most important to understand is the preolivar sulcus. Why? Because the preolivar sulcus is totally close with this corticospinal. If you enter in this sulcus, you can damage this corticospinal tract. That is the reason because sometimes you choose the entry point transolivar and not transsulcal access. Okay. This is the lateral view of the olive. This is the olive, like we all know. If you remove the back of the olive, this sulcus, you can find this tract. What is the name of this tract? Here, spinothalamic tract. In the back of the spinothalamic tract, you can find a little bit more posterior here. It's very slim, very, very slim. The name is rubrospinal tract, coming from the red nucleus to the spinal. Okay? This is the post-olivar access, safe entry point. We can discuss this point. You can access for the middle side, the name is transolivar approach or preolivar approach. But this approach, you must be careful with this structure, the pyramid, the corticospinal. If you make a cut here, if you push here, you damage the corticospinal tract. If you enter here in the middle zone of the lip, don't damage the pyramid. If you enter here, you can damage the rubrospinal and the spinothalamic tract behind. No more. And this is the inferior cerebellar peduncle. Okay, it's no matter. The access to this area is for this approach is schematic. Of course, this is the specimen in the lab. The far lateral approach, if you see, the far lateral approach can show you this area, all dissected, this area. The posterior lateral aspect of the medulla oblongata, the lower cranial nerves, here the olive, and here the inferior triangle of the foreventricular fold. Here, what is this? The obex, cuneatus and gracilis nucleus. Here, this is the surgery, like I told you. Here we access transolivar. You can see very, very well the disposition of the dissector. Inside, I try to remove the cavernoma inside of the olive. This is the posterior and lateral aspect to the medulla oblongata. This is the 11th nerve, of course. We push a little bit for superior the surface of the cerebellum to expose this area. You can access also by another approach, the retrosigmoid approach. This is the retrosigmoid approach. Step by step, you must understand the very good the landmarks to make the craniotomy. Everybody knows the craniotomy. Everybody knows this. It's real simple. You have many windows in the retrosigmoid approach because you can go extremolateral retrosigmoid approach also, like yesterday the professor said. Here you see the 5th nerve. Here the 6th nerve. This is Dorello. This is the 7th and 8th. This is the lower cranial nerve, of course. You have two windows between the 5 and 7 and 8, and below to the 5 and 7 between the 7 and 8 and the lower cranial nerve. This is the flocculus, and if you see the flocculus, you be sure you can see the choroidal plexus. But if you see the flocculus, in the upper part of the flocculus, in the upper part, you see a little bit more here. What is this? The lower aspect of the 5 nerve. But what is this? The lateral face of the pons. If you are here, you be sure, posterior, what is this? Middle cerebral peduncle. In that way, if you have one cavernoma here, you push with the spatula in the middle zone of the cerebellum, and you can expose the middle cerebral peduncle. Here, perfect. Okay, it's no matter. Here, this case is to discuss after. Maybe when we finish, I will really like to discuss with my colleagues what is the best approach in this case. We don't make the surgery, yes, in this patient, but I want to discuss with the most experienced colleagues here in the auditorium what is the best approach. What is your approach? What is the safe entry point for the people in this room? What happened with the tracks in this area? Damage or not damage the area? Oh, this case, it's okay, no matter. Just to finish, the access to the foreventricular floor. This is the real challenge for us. For me, sure, because to understand the floor of foreventricle, you must know what happens if you dissect the foreventricle. What are the most important structures? You can read the best paper, I think, for us in Argentina. We have the honor to know professor here from Italy. I remember my first lecture was the Professor Bricolo about the brainstem, about the foreventricles, master. But this is the foreventricle like we all know. But what happens if you dissect the foreventricle? You see, this is the foreventricle. You can divide in superior triangle first. Don't forget, superior triangle. The middle zone, second structures here. The second point, middle portion. And the inferior triangle. Three parts, superior triangle, middle zone, and here, inferior triangle. What is this structure? If this is the forenerve, you be sure, if you see the forenerve, here, medially, superior peduncle of the cerebellum. Why? Because the superior peduncle of the cerebellum made the lateral wall of this triangle. It's very simple. If this is the superior triangle, superior cerebral peduncle, what is this? You can divide this area in two. The more lateral is the medial cerebral peduncle, and the more medial, if you continue with the vision, is the inferior cerebral peduncle. The inferior cerebral peduncle is to here. In this way, the inferior portion of the foreventricle have two walls, two lateral walls, one wall, another wall. This wall is made by the inferior peduncle, the superior wall by the superior peduncle. The medial peduncle of the cerebellum is no matter, never touch the foreventricle. Now, what can you do to access to this area? Of course, the first time in the first word I can tell you is this is the most problematic area. The superior triangle have 3 or 4 access to understand. The first is the supracollicular approach. Supracollicular approach. Yesterday we talked about this because to understand this approach you must see first the superior fovea. Is this depression here in the upper part of the facial colliculus. If you in your first vision you look, you find, you looking inside in the brain, for example in your approach, in your televelar approach, you find this depression. You be sure below is the facial colliculus. Laterally, the central sulcus. This is the central sulcus, the medial line. In the lower part of the facial colliculus, you can enter here in the lower part, but it's very difficult to understand this area because you can damage the facial colliculus. The most safety is here. Some people say for the middle line, but the problem in the middle line, you damage the medial longitudinal fasciculum. And in that way, you can damage the connection between the 3, 4, and 6 nuclear nerves, okay? And another point to entry, of course, it depends of the damage. You can enter here, lateral to the facial colliculus. What is this area? Acoustic area. Here, the nucleus of the acoustic nerve, of course. 1 point, 2 points, middle line, and inferior to the facial colliculus. Why I can put these red points here? Because it's impossible. For me, it's very difficult. Just in the case when one cavernoma make a hole or make the pathway for you. Because if not, you damage 12 and 10 nerve. Of course, here is didactic representation. Here, many structures. You know, everybody know the books show in every book this structure: facial colliculus, supracollicular approach, vestibular area, acoustic stripe, many. It's no matter. But what happens if you remove this? What can you see? This is the question. One case. To access to the foreventricle, this is the dissection in the laboratory. Here you have telovelar approach. The telovelar approach, step by step, to understand how far you can go. You can push the lower part of the cerebellum and you can see the floor of the foreventricle. This is top, this is down. You can see this is the 11th nerve, of course the lower cranial nerve, 7 and 8. You push the tonsil. The tonsil are be pushed to expose the lower part. This is the lower triangle of the floor of the foreventricle. This is down, this is up. This is the upper part, this is the more inferior part. Here, the vertebral artery, the pica, of course. If you take off the pica, you can see the floor of the foreventricle. You see choroidal plexus and foreventricle floor. Yesterday I showed you in the laboratory the same imaging. Here the lower part, here is the upper part. This is the aqueduct. This is the superior velomedular. This is the superior cerebral peduncle. One side, opposite side. This is the floor of the foreventricle. If this is the middle line, here is the facial colliculus. Here is the vestibular area. If you take off the inferior velomedular, you can expose the lower part of the foreventricle. This is the floor of the foreventricle. You see? This is totally dissected area. You can see very well. Yesterday we do the same. The anatomy is very interesting because it can show me many structures to understand the approaches. This is the superior velomedular, superior cerebral peduncle, middle line. Here, you see, this prominence is the facial colliculus. You see this is the depression. If you find the depression, you be sure, medially, you find the facial colliculus. And now, I told you a few minutes ago, the lateral wall of the inferior portion is the inferior cerebral peduncle, here, running. Here, the inferior cerebral peduncle. And here, the inferior triangle. Very nice. Why is the anatomy is so important? This is in my language. Because yesterday, Professor Subianov said, Max, you can show me if you retract the lower part of the cerebellum. Of course, you can see very well the nucleus of the 12, the nucleus and the 10. This is the obex. This is the shape of calamus scriptorius. Here, the calamus scriptorius. Here, the obex, gracilis and cuneatus, middle line. This is the good approach in the middle line, and you can approach for this point, But if you go a little bit more lateral, you don't damage the cuneatus and gracilis. You can entry for the posterolateral sulcus, always lateral to this tract. If you respect this tract, you go a little bit more lateral, and you can entry in this direction. In this direction. Again, the same. Oh, this was a cavernoma in the floor of the foreventricle, just the post-op cavernoma, totally resected, was fine. And one case, medulloblastoma in my hospital. We do this surgery. If you know the anatomy, it's very helpful for us to understand. And if you dissect totally floor of the foreventricle, the picture is this. What is this? Okay, this is the superior triangle. This is the middle part. If this is the middle part, what is this part? The lower part. Yes, a few minutes ago I told you the lower part is this. You have the ovex, cuneatus and gracilis, middle line, 12, 10. Lower triangle. If this is the lower triangle, this is the upper triangle, the most up part of the foreventricular floor. What is this structure? The nucleus of the sixth, but it's not like this because I removed this part just to understand the disposition of some fibers running from this nucleus to reach the sixth nerve in the anterior face of the pons. And if this is the nucleus of the sixth, this is the facial colliculus. Why? Because this is the nucleus of the seventh, lateral, always to the sixth nerve, to the sixth nucleus, sorry. If this is the nucleus of the seventh, this is the lower part. This is the inferior and horizontal part of the seventh nerve. This is the vertical portion, and this is the superior portion. What happens if you dissect in the inferior point to the facial colliculus? Here, the inferior fovea, the inferior axis. You can damage the tectospinal fiber tract. Here, central tegmental tract. Here, inside of the inferior peduncle, what is this? The nucleus ambiguus. The nucleus ambiguus. Of course. Now I show you the upper part here. What happened here? This is the branch of the seven, but I tell you, you can go to the superior fovea. Where is here? This is the point to access. Remember, if you access here, you don't damage the fovea, you don't damage the colliculus facial. Here is the safe entry point. These fibers are part of the superior cerebral peduncle. Today I told you the superior cerebral peduncle have inside here. What is this? The nucleus ceruleus. And this is the nucleus ceruleus inside of the superior cerebral peduncle. The superior cerebral peduncle is the limit, the lateral limit of the superior fossa. Okay, main structures, it's okay, no matter. This is the point, safe entry point. Remember this slide, this is the safe entry point. This is another more little safe entry point, of course. But, okay, this is the representation of the medial lemniscus, no matter, this is the lower part. The medial lemniscus makes the decussation at the level of the ovex. You see, the fibers coming, run, they are more anteriorly to the aqueduct, and after that, cross to the opposite side and go to reach the anterior portion of the thalamus. This is the medial lemniscus. Everybody knows that. The middle line, lateral and posterolateral. The closer view of the foreventricle totally dissected, of course. Again, this is the superior axis. Remember this point. And this is the totally view more close to understand very, very well the facial colliculus, nucleus of the seven, inferior branch, vertical branch, superior branch. This is the facial colliculus. What is this in the middle line? Somebody say? This is the medial longitudinal fasciculus. So in the books, you can read the medial longitudinal fasciculus connect the sixth nerve, fourth, and third nerve. But what is this structure? They are the acoustic striae. The acoustic striae running from the lateral side to the medial side and make connection with the medial longitudinal fasciculus and connecting this nucleus with the vestibular nucleus part. This area I remove because it's impossible to make the difference between each part of the vestibular nucleus. But this area is the vestibular area. And if you remove the vestibular area, always lateral to the vestibular area, you can find this. What is this? This is one part of the nucleus salivatorius. The nucleus salivatorius is always lateral to the acoustic area. What happens if you see this area? Tectospinal fiber tract is more deep. Central tegmental tract, ambiguous nucleus. Here, the nucleus of the 12. Here, nucleus of the 10. And another nucleus is no important. It's okay. A closer view, very, very, very nice view. You can see any structure here. Here, the lower part, the obex, 12, 10, calamus scriptorius. Here, the decussation of what? The medial lemniscus. The medial lemniscus coming from below and cross anterior to the obex and make the decussation and run to reach the thalamus, you know? And again, textospinal tract, central tegmental tract, ambiguous nucleus inside in the inferior cerebral peduncle, nucleus of the 7th, inferior branch, vertical branch, nucleus of the 6th nerve. Medial longitudinal fasciculum, one side, opposite side, acoustic stripe. This is the vestibular area. This is the salivatorius nucleus. You see the tract? I respect all tract. It's no damage. It's true. It's real. Exists. It's here. This is a schematic reproduction to understand how can you reach the many parts of the brain by subfrontal approach, sterional transylvian approach, pretemporal approach, orbitozygomatic approach in 2 pieces, mostly of the time, subtemporal approach, presigmoid approach, far lateral approach, retrosigmoid extremolateral approach, suboccipital telovelar approach, supracerebelloso infratentorial approach, occipital transtentorial approach, and of course, transnasal approach. The different aspects of the brain is okay, and again, the challenger for me is the use of the endoscope to reach the upper part, the middle, and the inferior part of the pons. It is a real challenge for me. This is so many articles, it don't matter, and you can read this all this presentation in this book. And we take this picture yesterday after in the night with my colleagues and friends. I want to say again, like yesterday, thank you very much to this city, to Professor Subyanov, for the attention, for the cordiality, to be very, very kind with us. For me, it's a real honor to be here. I don't have words. I can find words to describe this moment. For me, it's very important to connecting with my colleagues and new friends. This picture was passed yesterday. My new friends. And I want to say very, very much, thank you very, very much to this person. This amazing person, very, very kind. Thank you for helping me a lot to this presentation. Thank you, Robert. Thank you for all. Thank you for listening to me, to the people in the room, and my new friends in the laboratory. Thank you very much.
Thank you, Professor. Есть ли вопросы в зале к профессору? I have a question, Professor. When during a transalveolar approach, my transalveolar approach, my incision must be horizontal or vertical. Vertical.
If you go so far, you can damage the both sides. In the anterior side, you can damage the corticospinal tract, the pyramid. But the image and the temperature.
Okay. Thank you.
Always vertical.
Vertical. Okay.
I propose the vertical.
I understand. Thank you. Ну, сейчас по плану у нас кофе-брейк 10 минут, потом... Кофе-брейк 10 минут, потом лабораторию? Да. После, получается, живой хирургии. Получается, у нас в час живая хирургия, сказали мне. Потом, после лекции. Но? Сейчас? Тут, извините, тогда сейчас будет выступать профессор Алессандро Дукати с лекцией «Паллиативная операция, вагусная стимуляция».
Also for me, it's a big honor to be here to give my presentation about this particular aspect of epilepsy. It has been great to meet new friends and to see that we are friends of close people, so that it's like a family, neurosurgical family. It's very important, and we have to thank Professor Suviano for this. I will speak a very specific aspect of epilepsy, treatment of epilepsy, and particularly of vagal nerve stimulation. Just to give a frame, every million population, you have 20,000 epileptics. And about these 20,000 epileptics, 14,000 are drug responders, so that the problem with them is treated by drugs. But 6,000 are not responders. And what you generally have is that 1,000 among them have good alternative for treatment, that is elective resective surgery, either amygdala hypocampectomy or for temporal lobe epilepsy or extratemporal epilepsy. You can do some other treatment like allosotomy, diet, functional hemispherectomy, and so on. But the problem is that a lot of epileptics are without cure, actually. So to this point, we are interested in vagal nerve stimulation. What is drug-resistant epilepsy? It is defined as at least if after the use of two treatments, two drugs, you cannot have a good control of seizure, provided that the drugs are appropriately chosen for the seizure type, that is taken as described, and that they are well tolerated without too many side effects. In this kind, you have drug-resistant epilepsy. Of course, this definition is not valid for everyone, because if some people can tolerate very well one or two seizure for in a month, for instance, for some other it is not a good control. So it also a subjective definition for that. What about new drugs? As compared to old drugs, the efficacy is more or less the same. What changes a lot is the absence or the significant reduction of side effects in new drugs, but the enormous increase of cost for new drugs. The cost of drug-resistant epilepsy is very high. And this Helmers is a chief professor in US that has made a very interesting examination of the real cost, of the cost in the real life of 16,000 epileptics treated by Medicare. So that it's the basic cost of what you can have in the United States. And the mean cost is what you see here. It's 16,000 plus minus 45,000 US dollars. That is enormous quantity of money. And the real cost of drug-resistant epilepsy is not just the cost of the drugs. It's she computed for 6 months before the application of VNS the access of hospital, the traumatic brain injury, unemployment, caregiver loss of work, depression, not just the cost of it. So this is the cost for the society of a drug-resistant epileptic is very high, and you must compute everything that's going inside it. Several epileptics are also depressed, and that's increased the cost because and the severity of the disease. VNS is a good option for a substantial number of drug-resistant epileptics. It works as a neuromodulation, not just an on-off technique, like it is DBS, for instance. Which fibers are stimulated by vagal nerve stimulation? It's left vagus nerve in the neck. Why? Because left vagus nerve carries information mainly from the bowel, not from the heart. And so you can avoid easily cardiac effects. And then the intensity is chosen to stimulate mainly the afferent A and B fibers. And which central structures are affected by stimulation of this kind of fibers in the vagus nerve? This is the key slides in the presentation, because all the fibers that you are stimulating in the left vagus nerve in the neck goes to nucleus tractus solitarius. And from nucleus tractus solitarius, they can divide in 2 or 3 different pathways. The most important one goes to locus ceruleus, and from there go above the tentorium to the supratentorial structures like thalamus, hypothalamus, forebrain, insular cortex, and amygdala, or to raphe nucleus, to the reticular formation from parabrachial plexuses. And in another way of expressing this diffusion, you can have three main pathways. That one, perhaps the most important, goes through the locus ceruleus to all the supratentorial structures that I have illustrated just now, and 2 accessory ways go to dorsal raphe nucleus and parabrachial nucleus. So that this is more or less the network that is influenced by the stimulation of the vagal nerve in the neck. So you have effects on the gateway structures to the thalamus and specific targets like limbic system, nucleus tractus solitarius, and locus ceruleus. And just to specify, chemical destruction of the locus ceruleus virtually prevents any vagal nerve stimulation effects on epilepsy. So it's really key structures for that. But which neurotransmitters are affected by this stimulation? VNS produces a diffuse release of GABA, noradrenaline, and glycine in the brainstem and in the cortex. A reduction of so GABA, noradrenaline, glycine are inhibitory mainly, while glutamate and aspartate are excitatory. So you have an increase in inhibition and a decrease in excitation of neurotransmitters, and a modulation of serotonin. This has been proved in chronic studies in animals. Therefore, cortical excitability for neuromodulation, plasticity of the brain, you have a desynchronization of cortical activity through stimulation of the amygdala, thalamus, and limbic cortex. and reduction of interictal epileptic spikes. This is the effect in the long run of VNS. And is it a persistent effect? Yes, because it is a chronic stimulation, reduced cortical excitability, and it can also affect, have a neuromodulation effect in the immune response. That is very important both for epilepsy and for other disease. What is the indication for VNS? You have to have good effects in any kind of surgery, of decision making for patient. You have always to find the correct patient, because if you don't choose the correct patient, you have a bad clinical effect, and you also make a very bad service to the technique itself. Because if you use a good technique for the wrong patient, you will have no effect, and therefore it will be a failure of the technique. So the indication should be chosen very well. Patient with partial, multifocal, bilateral, independent foci that are drug resistant and not amenable to surgical resection or after failed surgery. This is the main point. And possibly this kind of patient sum up to make one half of the patient that are left without cure. So that means that every million population you have 20,000 epileptic. You remove the drug responder. You remove the other people who can have an effect from resective surgery, and you are left with 5,000. 5,000, one half of them, more or less 2,500 per million population, are the possible drug-resistant epilepsy that could have a good effect after VNS indication. What are the relationship between VNS and callosotomy? They are very similar indication because the choice of the patient could be rather similar, but callosotomy has more surgical risk, is a lesional procedure, therefore it is irreversible. What has been done, but has a reduced immediate cost and a quicker effect. For instance, if you have children of 3 months with catastrophic epilepsy and you need to have a quick effect, it's much better to go on and do a callosotomy than to have vagal nerve stimulation that takes months to be effective. So if you need a quicker effect, callosotomy is the correct choice. But VNS has very little or no surgical risk, has slower effect but persisting in the time, higher immediate cost but big saving in the long run, and I will try to demonstrate this later on. And you have also good collateral effects, that is improvement in depression. And of course, the younger the better. This is perhaps the younger boy I ever operated on. It was 6 months, and it's one of the few that is angle 1, so without no seizure and no therapy. Why did I speak about depression also? Because it's also observed that both in clinical evidence and in functional neuroimaging, you find that epileptic that are depressed become very much improved after treatment, and you can demonstrate also with SPECT that you have activation in the limbic system and brainstem during VNS therapy. Of course, there are contraindications also to VNS that are monolateral left or bilateral vagotomy and severe heart bradyarrhythmia, because some fibers also from the left may go to the heart, or serious infectious disease because you're implanting some foreign material in the body, so that if there is high risk of septicemia, it's better not to have some foreign material. What is the procedure for a new implant? It's the final situation is this. Oh, no, I don't know. So you have an electrode on the left vagal nerve and a stimulator that can be either immediately below the clavicle or below the pectoralis muscle for aesthetic region. Of course, you need a programming system. The case will take about 1 hour and a half. General anesthesia, generally. Left neck incision for electrode and subcutaneous pocket, and outpatient or overnight hospitalization. So it's very quick. Preparing the patient, you have to find out the correct patient. The position is like that one that you use for approaching the cervical column from, say, a CDF, something like this. So the neck must be right, a little extended, and you see here. I cannot have the light here. What, this? Yes. This is the clavicle. This is the mastoid here. Somewhere in between, on the left side, you make this incision. Transverse incision for aesthetic reason, like you do for cervical approach. And this is a real case. And the landmarks are always anatomical landmarks. You know that the carotid, you can find easily the carotid between the triangle, between the anterior sternocleidomastoidal muscle and the omoioideus muscle. So in the triangle between the two, you always find the carotid, and you can feel the carotid pulsating with your finger. And the point is that this is the portion of the nerve that you are supposed to stimulate, that is below the cardiac nerves of the vagus and above the recurrent nerve of the vagus. So this is free of collateral nerves. This is a long tract of the nerve. You need around 3 centimeters of nerve to apply this nerve. Look here, the nervus vagus goes up, and here is the dorsal vagal nerve, nucleus ambiguus, spinal tract, spinal nucleus, and nucleus tractus solitarius. They are closer one to the other one and very well connected, as we have seen in the magistral lecture that Maximilian Nunez has given to us. That has been really a masterpiece of neuroanatomy. So thank you very much. And this is a real case. You dissect the muscle. You feel the carotid. This is the carotid. This is the carotid. This is the carotid. This is the nerve. The nerve is generally in the angle between the carotid that is medial and the jugular vein that is lateral. In the angle between them in the back, you find the nerve. Inside the fascia, the middle cervical fascia that contains the vascular nerve. Oops. So then you prepare the pocket to put in the stimulator, and you put. So this is morphine. You see here, you place a piece of plastic below the nerve, isolate the nerve, and then put this three coils around the nerve, trying never to touch the inside of the coil, because there is where the contact should take place between the nerve and the electrodes. And you put it around it like this. It's shown very clearly here. And At the end, you will have 3 of them, and I will immediately explain the function of each of them. The lower one, so the lower one, it's 4 coils, and it is just an anchor. The middle one is a positive electrode, the upper one is negative electrode. What does it mean? That when you stimulate, you have the another block here, and most of the stimulation goes up. It does not go down, because there is another block here. So most of the activity is going cephalad. And this is a neutral thing, and just helps to keep the electrode in place in order not to have changes in this position. And this is how it shows at the end of the coiling around the nerve. This is the sternocleidomastoidal muscle. This is the electrodes. This is the coils. This is the electrode that has to be secured to the muscle in order not to move it. So during the application, you have to make a test to be sure that the stimulation of the nerve does not cause any change in the rhythm of the cardiac system, and that the impedance of the system is good. Because if you have deteriorated the contact between the electrode and the nerve, then the impedance goes up and you don't have any effective stimulation. So the impedance must be down like always. And this is the effect in the long run. It's just a small sign that is similar to the usual sulcus in the neck. More than 100,000 procedures have been done in the world with this technique, so that we know very well all the side effects and all the natural history of this treatment. We know that most of patients require a new implant after exhausting of the first battery, and this testifies the effective goodness of the procedure. There is no interaction, with drugs, and serious complications are below 1%. SUDEP, that is one that is feared by the epileptologist, has happened also with VNS, but it happens also spontaneously. And there is no significant increase of SUDEP in patients treated with VNS as compared to the people not treated well. The most important complication is really infection. So you must be very careful not to be very sterile technique. How can you evaluate the efficacy of VNS? It's not just the reduction of seizure, because you must always remember that you are dealing with a population of severe epileptics, in which there is a burden of work both for the family and for doctors around. So it's not just the number of seizures that must decrease, but it is also the severity of the seizure. It's different to have a seizure with drop down and falling and hitting your head and requiring hospitalization because of the traumatic head injuries, or have a very short seizure that leaves you more or less without any consequence, maybe sitting on the chair with no consequence from no point of view. And that means that you must have a reduction in hospital admittance because of seizure, but also because of any other reason. Because what has Helm proven that the number of hospital admittance for any kind of reason has been reduced after the implantation of VNS. In that, I repeat, 16,000 population taken care by Medicare in the U.S. So normal population, not private insurances. And another good side effect is the reduction of work loss by patient and caregivers. This is another point. What you see, a difference with the drugs, in which you have generally a very good effect immediately, and then after a few months you have a reduction of the efficacy. This VNS is exactly the opposite, because it is a neuromodulation. It is not an on-off effect. So even though in the beginning you have 3 months later, you have just one-fourth of the patient that is responding to this kind of therapy. After 3 years, it's 42% in this study. But in this one, you have more than 50%. And you see, the longer, the better, because neuromodulation takes time to be effective. And this is just the number of seizure, not the total cost of seizure. That is another point, and it is, as I told, even more important. And if you treat a population of children, it's even much better, because the children are more responsible to this kind of therapy. And after 3 years, you have around 91% that has had a significant reduction of seizure for that. And this is a production of another paper done not by us, but another group, so that you can sum up that while neuromodulation is going up in the effect and with reduction of side effects, like we will see later, drugs, the efficacy of drugs is the opposite, and it goes down from 80% of responders in the first year to 40%, but with an increase of side effects, like it happens very often. So it's not just the number of seizures that matters. What makes the difference are the severity of seizure, the reduction of hospitalization, and the impact of everyday life for patient and caregivers. This is testified by the fact that most patients ask for replacement of the battery when it is exhausted. Even still, they may have several number of seizures, but the severity of seizure is much less. This is the work by Elmes. You see that the 0 point is the cost of this 16,000 epileptics taken care by Medicare in the 6 quarters, 1.5 years before the application of VNS. So if you put this at 0, you have that immediately in the first quarter you have an increase of cost because of the cost of the stimulator. That is significant. It is around $20,000 US. But then, due to the effect of the VNS, after 1 year, 1.5 years, you have even a break-even here. And from this on, you have a significant reduction of cost for all the payers. That is mainly the insurance or the state. It depends on the health organization of your state. And this is what you spare after 4 years of application. The life of the battery generally is between 4 and 5 years. So this is what you can put on the budget to convince your administrator that it's not only effective, but it is cost effective. Major complications are 1%. I've seen only one severe complication. It has been a case that has been operated in another city very far away from Milano, and the young boy had several infections, and after every infection they removed part of the lid until leaving a small part close to the nerve. And this is a big error. If there is a severe infection, you have to remove everything. Because in this case, what happened is that the chronic infection, several years of infection, very close to the carotid, made the carotid very fragile. So that when I removed the electrode on the nerve, I had to place also a stent in the carotid artery in order to avoid the breakage during surgery. And that has been the only case I observed of severe complication. Side effects are hoarseness, because during stimulation, that is 30 seconds every 5 minutes, the patient can have some hoarseness, but they tolerate it very well, and it decreases over the years. And the same is paresthesia, so that VNS is a good option for a substantial number of patients. Very often it is denied because of the cost, but the cost of drug-resistant epilepsy in the real world is much more than the cost of the VNS device per se, because you have to consider all the collateral costs. So to sum up, this is my take-home message. Figures are coming from Italy. Every 100 epileptics, you have 65 that are treated by drugs, and 70% of them are cured by drugs, so that no problem. But 35 are drug resistant. Among these 35 drug resistant, 10 patients are unifocal. And being unifocal, they are good subject for resective surgery. And 8 of them are cured by them. Only 2 are not cured. So it is very important to identify these 10 unifocal patients that could be could undergo elective resective surgery. But still you have 25 multifocal. Some of them are the ideal candidates for callosotomy because of the reason we have spoken about before. 20 of them, plus the 2 coming from the failed surgery, are good subject for VNS. And you may expect 70% of improvement in them in terms of reduction of seizure and reduction of severity of seizure and reduction of cost for all the caregiver and the patient. So the conclusion is that there is no competition between the different types of treatment of epileptic patients. There are only different indications. So you cannot apply all the therapy, the same therapy to all different patients. Every surgeon has to be familiar both with treatment of temporal lobe epilepsy, of extratemporal lobe epilepsy, callosotomy, and also vagal nerve stimulation. So this is very important. This is my town, Torino. Torino is a very nice town in the north part of Italy. It was the first capital of Italy. And if you want to come anytime, I will be happy. Thank you very much for your attention.
Thank you, профессор. Есть ли вопросы в зале к профессору?
Thank you for the lecture. Just to know, you find some relationship with, for example, when you resect some low-degree glioma in the insular part, the relationship with in my case, I see some patients with depression without tumor. That is the reason because you show the connection between the nucleus ceruleus and the corticostriatal fiber, something I can understand very well in my case, but that can be the reason?
Yeah, it might be the reason. It might be the reason. It's been proven on a large group of patients undergoing VNS therapy that that the depression is very well treated. We also have a small group of major depressed without epilepsy that has been treated by VNS, and I must say that they were very severe, so suicide people, not just reactive depression. And most of them had an excellent effect. So this is very important. And then changing the parameters of the stimulation, you may also affect different aspects of immunity. For instance, I participated in a large study, experimental study, to treat chronic inflammatory disease with VNS, like Crohn's disease in the bowel, for instance. Because changing the parameters, we affect both the secretion of steroids and also direct effect on macrophages. So it's really a complex matter. Neuromodulation is a very complex matter that we cannot explain the mechanism of each one, but we know at least the black box, what comes out from the black box when you apply it. So, thank you for that.
Есть еще вопросы?
Thank you.
У нас немного изменения в плане. Сейчас будет кофе-брейк. Ага.
Мы решили немножко изменить формат проведения. Обычно мы награждали в конце. Это некий такой неотдых, потому что надо было заканчивать вовремя, там, еще хотели диссектировать, там, и так далее, пообщаться. Поэтому, может быть, мы сегодня сейчас вышлем сертификаты, официальную часть закончим, а потом спокойно уже без limita можно там и оперировать, и потом диссектировать, и без limita в лабораториях. Давайте так сделаем. Because little bit change the format, because usually standard the finish day is something difficult, like continuous, some dissection was in the dissect video, but we must stop it, come here, certificate, water, which we do now. So end of the day will be free for dissection, for light surgery, for fun, or something like that. Okay? So maybe we do certificate now. Okay? Так, участники. Так, Нураджон Уматалиева.
Thank you. It's beautiful lecture. Thank you very much.
Thank you very much. Сабина Нагиева. Девочки, вы не стесняйтесь. Это же жизнь, надо учиться говорить. Поздравляю. Тут же все свои. Нет,
Thank you very much for these 3 days. It was really great lectures, and it was really great experience. Thank you very much.
Да. Диана Зейналова. Не надо заражать людей, конечно. И сам Балу. Судан. Is our resident. И сам ничего на английском задвинешь? Поздравляем. Фото. Коммент.
Thank you very much. I really privileged these days to attend famous researchers, practitioners, professors from around the world. For me, this is a very nice moment, and thank you for all sharing the experience. Thank you for you, Professor Albert Akramovich, for leading this institution.
Thank you very much. Thank you. Good luck. Рамиз Алимов. Рамиз, представься, откуда? Поздравляем. Фото.
I'm from St. Petersburg. Thank you for all lectures. It's the great presentation. Especially thank you, Maximilian Nunes. It's excellent anatomy lecture. It's great lecture. And it is a very important course. Thank you for you.
Thank you. Good luck. Алексей Митрофанов.
Митрофанов Алексей, Екатеринбург, Урал. Я хочу сказать, Митрофанов Алексей, хочу сказать немножко слов благодарности. Я искренне благодарен руководству корпуса, нашим замечательным лекторам. Они позволили мне очутиться в таком фантастическом, чудесном нейрохирургическом сне и провести в нем эти 3 прекрасных дня. Но все заканчивается, к сожалению, приходит время просыпаться, расставаться. Это очень жалко, конечно, что так быстро все пролетело на одном дыхании. Я не в первый раз приезжаю в Федеральный центр нейрохирургии к Альберту Акрамовичу, где так много делается для нейрохирургов различных возрастов, различных направлений. Каждый раз, приезжая с цикла, уже по-новому смотришь на, казалось бы, привычные вещи какие-то, над которыми раньше не задумывался. И отдельное спасибо, конечно, что есть возможность воочию встречаться, общаться, слушать лекции, делиться опытом с, не побоюсь этого слова, это так и есть, со звездами мировой нейрохирургии. Раньше этого просто, было даже невозможно представить. Благодаря Альберту Акрамовичу эта возможность теперь у нас есть. И как правильно построен цикл нейрохирургии, обучающий цикл здесь. На самом деле знание анатомии, прекрасное знание анатомии, возможность диссекционировать, выполнять доступы, это является ключом к формированию адекватного нейрохирурга. В наше время, когда я начинал путь нейрохирургии, это было около 20 лет, не было такой возможности, приходилось учиться по атласам, но это не дает глубокого представления об анатомии. И, конечно, в работе ты начинаешь сомневаться, совершать ошибки, быть скованным, иногда не понимать, что нужно сделать, и это тормозит прогресс. А с другой стороны, если человек попадает в правильное место, где мы сейчас находимся, и сам приложит много сил, перед ним открываются любые двери, как нам продемонстрировал наглядно в лекциях Максимилиан Нуньес, свои прекрасные клинические случаи, очень сложные, невообразимые. Спасибо вам за это. Еще хотел, конечно, сказать слова благодарности силам Альберта Крамовича, вашему прекрасному коллективу, где все, конечно, являются бесспорными профессионалами, но в то же время остаются такими открытыми, добродушными, готовыми к диалогу людьми, создающими домашнюю атмосферу, которая помогает еще больше погрузиться в процесс, вот в этот обучательный процесс. Вы делаете правильное дело, Альберт Акрамович, нужное. Все, кто ездил к вам, жутко благодарны за то, что за ваши циклы. И, как нельзя лучше говорит о том, что даже из клиник с 40-летним, 50-летним историей приезжают к вам на работу, на ординатуру, они даже не остаются там, а это говорит о вас гораздо лучше всех слов. Спасибо вам огромное. И еще хочу сказать, конечно, отдельную благодарность нашим удивительным лекторам, которые то, что вы продемонстрировали, это за гранью фантастики, понимания. И я теперь понял, что такое быть настоящим нейрохирургом. Обязательно, когда приеду к себе в город, сяду за анатомию, чтобы хоть чуть-чуть приблизиться к вам, к эталонам современной нейрохирургии. Спасибо вам, удачи.
Молодец, спасибо. Удачи вам. Интересен? Как-нибудь зайди ко мне сегодня, ладно? Ибрагим Салам. Ибрагим Салам. Давай. Давай.
My name is Ibrahim Salamov. I'm a resident first this center. Of course, I want this conference very important for me because I want to be functional neurosurgery in the future, and I tell thanks for professors which presentation for us our residents these amazing and excellent lectures and anatomy and dissections in laboratory. And like I told yesterday, Professor, this conference watched not only this auditory, and we have a close internet chat with young neurosurgeons of Russian. This is student medical students and residents or on another centers. This is 500 residents, medical students, and they tell to you great thanks. And thank you, professors. This is important conference. I very glad, especially when we do conference, because for us, for our residents, this center, we very lucky.
Thank you. Спасибо. Руслан Мусин.
Всем здравствуйте, меня зовут Руслан Мусин, я ординатор первого года на Федеральном центре нейрохирургии. Хочу сказать спасибо нашим дорогим профессорам, лекторам за столь чудесные лекции, очень информативные, они просто были изумительные. Мы много для себя узнали, много для себя поняли. Большое вам спасибо. И большое спасибо руководству центра Альберту Акрамовичу за потрясающую возможность познакомиться с такими людьми, увидеть их воочию и что-то перенять, узнать что-то новое. И за такую возможность стать намного-намного лучше. Спасибо большое.
Спасибо, удачи. Эмиль Буладжев. Эмиль. Так, теперь мы перейдем к такой заключительной части награждения церемонии. Она очень важная. Почему? Потому что
Ну, удалось собрать, было непросто, просто блестящий коллектив лекторов, вот на самом деле. И этому я посвятил несколько лет, на самом деле, вот именно вот в этом варианте этого курса. Вот. Почему? Вы понимаете, что все люди приехали с разных концов, кто-то из Европы, кто-то из Южной Америки и так далее. То есть наши российские лектора, то есть, ну, и вот всех в одном месте сконцентрировать, особенно профессионалов такого класса, ну, я бы сказал, ну, уникальных людей, ну, было непросто. Списывались несколько лет. Maximus, like this, yeah? So, many years we tried to collect here these beautiful lectures in this place. Вот поэтому всем лекторам большое спасибо, и поэтому я это хотел бы очень особенно отметить, низкий поклон, я надеюсь на сотрудничество. Но самое главное, конечно, нашим резидентам и участникам, общайтесь. Самое главное, это те связи, которые вы сейчас вот с такими людьми заведете. Это ваше богатство на всю оставшуюся жизнь. Поэтому первый лектор — это Александр Орлов. This is the chief of functional department, very famous neurosurgeon now in Europe. More than 1,000 DBS. This guy. More than 1,000 DBS. 70, near the 70 головного.
I'm doctor of this center. My dream was to be a doctor of functional neurosurgery, and I'm very fond of stimulation technique, deep brain, spinal cord, and also peripheral nerves, vagal nerve stimulation. And we try to use these techniques for our patients to deliver some difference in their life. And I think it's the most important for us as doctors, and of course for us very important that knowledge that all of you bring to us, because it's very hard from Tumen to reach Moscow and Europe and South America and also so on. Thank you very much for this course.
Thank you, thank you. As a brief remark, when I come to this place and the government give me the test, you must build the current high technology center in neurosurgery in this land, Tumen land. When I come here, no neurosurgeons, no nurses. So Alexander is my first student in neurosurgery from this local region, because I understood only I am alone not possible to create, and so I try to choose the people. And this is the first people what I choose to my team, and I promise him, you will be number one in Europe, in DBS. He not promised me this time, but now he's number one. Okay. Okay. 1,000 DBS. Number one in Europe now. Igor Markin. He not promised me. When I explained to him, you must go with me. We must build the center. Because he works in regional hospital. Standard neurosurgeon. I teach you. Okay. Igor Markin, поздравляю. Лектор. Нормально. Инструктор даже. Это круче.
Thank you for the great lecture, great anatomy, wonderful anatomy, wonderful presentation. It's very expensive for me. This day is a beautiful day. But we don't finish now. We go to the lab and work. Thank you for.
Thank you. Good luck. Рустам Талуров. Рустам, поздравляю.
Hello, I'm Rustam Talibov. I'm head of radiology department, and thank you very much to all of us here. And it was great lecture. Thank you, professors. And we have the great radiology department, and Professor Sufyanov made all of them. We have great MRI scanners, CT scanners, and we're happy. Thank you.
Александр Скибников.
Спасибо. Александр Скрипников, врач функциональной диагностики Федерального центра нейрохирургии. В эти дни мы очень активно общались с гостями конференции. Удалось узнать много полезной информации, в частности о диагностике при хирургии эпилепсии. Будем осваивать, будем практиковать. Всем большое спасибо. Thank you very much.
Спасибо, удачи. Профессор Александр Дукати. Alexander, thank you very much for coming. Thank you. Thank you. One photo with me and some comments.
Big honor to be here to meet you and to meet other friends from all the world. I'm really impressed for the quality of your cooperation and the high standard of your hospital. So many congratulations.
Thank you. Thank you, Alexander. Thank you. Good luck. Профессор Бруно Коста. Белого горизонта. Бразилия. Bruno, thank you. Really, thank you. I really enjoy it. Thank you. Some comments, okay?
Yeah. I'd like to say thanks to everybody, especially Professor Sufyanov, Ailia, who was very kind and received us here. And when I was invited to here, my friend Luis Borbas tell me it's an amazing place. It really is an amazing place, and it's the best neurosurgery service in terms of technology and conditions to do the things. A very, very good laboratory. You have all the things in hand to do an excellent service. Thank you.
Thank you. Thank you. Good luck. Ольга Змеенко. Ольга, поздравляю.
Спасибо. Спасибо.
Фото. Два слова, представьте.
Да. Спасибо большое. Спасибо всем гостям нашим, уважаемым. Каждый год мы рады и новым гостям, и тем, кто уже не первый раз к нам приезжает. Это всегда очень интересно. И мы рады всегда поделиться своим опытом и знаниями. И каждый раз всегда все по-новому происходит. Спасибо Альберту Акрамовичу, что всегда все на самом высоком уровне. Я надеюсь, что это в следующем году опять мы встретимся с новыми гостями и с нашими гостями, которые уже приезжают к нам постоянно. Спасибо большое. Я думаю, что было интересно всем. Спасибо.
Спасибо большое. And this is certificate for our mentor in epilepsy surgery, the man who opened a new page in our Federal Center of Neurosurgery, page named by epilepsy surgery, Roy Daniel. Thank you. Yeah. You are really good. Okay, some comments.
Okay. Thank you, Albert. Every time I get an invitation, I always love coming here. But nowadays it's becoming less and less like an invitation because it seems like coming home to the family. And thank you very much.
And I would like to special thanks for Aliyah and Anna for organizing everything. And the team in epilepsy surgery, I want to congratulate you. It's fantastic now. And every time I talk to Olga, Stefan, and Yuri, and Alexander in the operating room, you have a fantastic team, and it's a pleasure to do surgery here. Bravo, congratulations.
Thank you. Good luck. Thank you. And today it's very important for us. I want to present and give a certificate for our honorable guest, Maximus Nunes. Maximus. Thank you. Thank you. It's really. Okay. Some comments. Okay.
Okay. Okay, like I tell you, yes.
Special lecture, brainstem approach and anatomy. Really very special in the world.
Like I tell you before, thank you. I can find some words to describe. Was an honor to accept this invitation for Professor Suyanov, but I think the most important is to know the new people. I never was in Russia. I just to say thank you for the new friends. Thank you very much for helping me a lot. Thank you very much. Thank you everyone to pick up. Every part of this department was very kind with me. I don't have a words. The life teach me to know new people, to do new friends in the life. For me, I think that is the most important part in the life. When you see back in the future, you can see many friends around the world. Today, I have new friends. I have new friend Robert. I have new friends from Italy today. Just one day, and you can make a new connection with the people. It's not just neurosurgery. It's not just anatomy. It's one with each other. This is the most important for me. This is a big moment. Just thank you, doctor. Everyone are welcome in Argentina, and I hope someday come back to here and again say thank you for being so kind with me. Thank you very much.
Okay. Max, thank you again. Welcome to family. Welcome to family. Okay.
Well, it's a great pleasure to now give the certificate of appreciation to Professor Sufianov, the man responsible for the center, the conference for everything in human.
Thank you. Okay, ладно. Так, все? Всех наградили? Так, ну, значит, рабочий день не закончился. Это только начало рабочего дня, серьезная работа в лаборатории. Теперь сделаем фотографию общую на память, хорошо? И потом двинемся по всем нашим делам. Кофе-брейк и так далее. Окей? Все, фото. Please come here.
Блоки перевода задайте, пожалуйста, при выходе.